Okay, everybody, welcome to tonight's webinar. Welcome to our webinar. I'm Dr. Stephen Fallon. I'm hosting, and we have Dr. Nahid Mohammed here who will be doing most of the teaching. Nahid, you're here?
Yes, I'm here.
Awesome. So thanks for joining us, everybody. I know we have a lot of people registered from all over the world. Maybe let us know where you're joining us from in the questions section. We will take questions. I'll ask Nahid all the different questions we get at the end of the webinar. So you can use the control panel, type in any questions that you have, and do my best to ask Nahid the different questions that come up tonight. You're in for a treat. We're going to talk about extractions and socket grafting. And this, in my opinion, is a very important topic because I think this is something that is done on a regular basis in our practice, extracting teeth, and having the ability to graft all of these different types of sockets is a big bonus for our patients. This is a big service that we can help patients with, even if they're not immediately planning to place an implant. This is still a benefit for them. A lot of the time down the road, they might want to place an implant, or they might want to place a bridge, or they might want a denture. Anyway, it's best they don't have a huge defect. So this is going to prevent that. So let's see, we've got people from Canada, New Jersey, Zimbabwe. All right. We've got a member here from Zimbabwe, Nahid. So that's like people from all over the world. So Texas. Oh, Will's here from Texas. Cool. Will's one of our members for many, many years. That's really cool. Nahid, you were born in Africa too, right?
I was born
Were
here,
you
but I
born
grew
there?
up. No, I was born here actually. I lived here for a year, and then I we moved back. So I grew up in the Congo, the
In Congo, yeah. And
Democratic
when did you
Republic.
come back to America, Canada?
In high school, there was a civil war there, so
Oh,
I had
jeez.
to come back as a refugee.
Wow. Wow. That's quite the story. There must be a lot there.
Yeah.
Wow. That's crazy. We've got people from Bermuda, a lot of people from America, Pennsylvania, Florida, all over the place. So I think we'll get right into it, everybody. I'm not going to hold things up. So Nahid, I'm going to turn it over to you. I'll mute myself. I'll come back at the end to answer or to ask you the questions. Everybody can keep throwing out questions, and we'll be happy to do our best to answer all of these questions. So Nahid, take it away. We're looking forward to it.
Okay, guys. So I guess I've been asked to do this webinar a couple of times because extractions and socket grafting is one of the most common procedures people do in their practice. Everyone does extractions, whether you do implants or not. And if you can do an extraction to add the addition of doing a socket graft is quite easy, and it has so many benefits. And not only if they're doing an implant, you benefit the site because one is you're maintaining the volume of the ridge. So whether you're going to do a bridge or a denture, a wider ridge is going to look more natural, more aesthetic to preserve those contours, so you get a better result. The denture will seat better on a wider ridge. A pontic site will look more natural sitting on a grafted ridge. Even, you know, from my experience, and I'm not sure if there's any research or articles to do this, but when you graft a socket, you greatly reduce or minimize the chance of a dry socket. I don't think I've ever had a dry socket in any of my cases where I've grafted the socket with bone. So it's almost like the bone itself triggers a remodeling phase, it triggers vascularization, and it prevents a dry socket compared to just removing a tooth on its own. I think because the graft itself helps stabilize the blood clot, you have more volume in it. So it prevents dry sockets. So, and it's a fairly easy, quick thing to do, which we're going to talk about and show today. So I'm going to be discussing two things. We're going to be discussing the removal of the tooth, which is, just as important as how we graft it. And we're going to talk about different types of sockets, when they have different varies of bone loss and loss of the buccal plate, and how we address those different sockets, and also sockets in the aesthetic zone and severely damaged sockets. So we're going to go through some of the basic background of biology, what happens when you remove a tooth, And then we talk about the concept of socket grafting. I very quickly summarize bone grafting materials for you. We kind of make it simple as part of those of you who have taken my courses. I try to kind of filter out all the crap and just make it very streamlined and simple for you to be able to just take this information and start using it in your practice. And then we'll end by showing some cases of various degrees of extractions and socket variations and how we treat them. Okay, so when we talk about socket graft, the term ARP or alveolar ridge preservation was coined, and this is basically when you remove a tooth, you basically get significant resorption and remodeling of the socket with both the bone itself and the soft tissue, which can affect the aesthetics and the functional rehabilitation of the site. Okay, these ridge preservation procedures have been found to be effective in actually reducing the amount of volume change that you have, and it reduces the negative impact of this resorptive process on the socket or the ridge when you extract a tooth. Today, most people are more concerned about aesthetics and the way things look. And I think, the demand for a certain type of result has become almost, not like a bonus, but it's almost like it's expected. Okay. So today there is an increased demand of having an aesthetic and natural looking result in dentistry. And so, because of this, it's even more important to maintain the ridge volume in order to achieve an aesthetically long-term stable prosthesis. For example, if you were to do a bridge and you don't graft the site, and the patient then realizes that hey, this pontic kind of looks fake. It looks like it's just sitting over the ridge, and over the past year or two, I've noticed my bone is thinned out, and now it kind of looks like there's a space there, and I keep getting stuff stuck in there. So this is something that this sort of scenario could be easily prevented by doing some sort of alveolar ridge preservation at the time of extraction. And so it's almost like an expectation now that you should have sufficient volume of both hard and soft tissue when you have a tooth replacement prosthesis, whether it be a denture, a bridge, or an implant. And a lot of this time that you have to sort of assume that the patient expects this because they don't really know what you're doing and they don't really realize until it's all done, and then they say something is off, something looks wrong, this doesn't look natural. And if you say, well, we could have done a bone graft or something else, some tissue grafting to increase the volume, uh, but you denied, or let's say you refused to have the bone graft, and they're like, well, you didn't really explain to me that the bone graft would increase or preserve this ridge and make me look more natural. If you had told me that, I would have said yes. So sometimes it's also communication with you and the patient, and most of the time this may increase your acceptance, for having or completing a ridge preservation procedure. There'll still be some people that will say, you know what, it's okay, I don't want it, I don't care about the way it looks. And what we find is basically this need for alveolar ridge preservation when extracting a tooth is is important, basically, whether you're going to do a bridge, a denture, or even an implant supported crown, okay, or prosthesis. If you don't and you leave it for years, you can end up with something that looks like this. And now when you get something like this, it requires a lot more effort, a lot more trauma, a lot more cost, and a lot more time to do a larger grafting procedure, whether it be, a larger GBR or even a block grafting procedure, like in this case. Okay. And so what we know and what we learn from basically the biology of bone is that bone requires stimulation in order to maintain its form and its density. Teeth, when they're in the socket, they transmit, compressive and tensile forces to the surrounding bones, almost stimulates the bone. So when you remove a tooth, you get lack of stimulation to the residual bone. You cause a decrease in the trabeculation and the density of the bone, and basically you get bone loss volume. It's almost like, you have a muscle. If you don't use it, it will shrink. When people have let's say if they break their arm or their leg and they have a cast around there for a few weeks or months, when they take off their cast, their arm looks or their leg looks really really thin and small, and that's because nothing has moved there, and so the muscle volume and everything has shrunk. So it's the same concept. If tooth is removed, you know, among other factors, the lack of stimulation is one of the reasons why you get this loss of volume. Now, what happens if you look at these cross sections from left to right? The cross section on the left images, you'll see the tooth and the actual jawbone. So you can see tooth, alveolus, and basal bone. As you move from left to right, you can see tooth is removed. You get some resorption remodeling. Over time, it shrinks. You start to see the alveolus start to shrink even more. It starts to shrink now in vertical height. And if it's long enough, like 50 years over time, they end up with literally nothing but just basal bone, which you pretty much see in the last two cross sections on the right side. So this process of slow resorption is what we want to try to prevent, and we prevent this by sometimes ridge preservation procedures, and as well as something that will stimulate the bone. So what happens when you pull a tooth out? So we're going to discuss socket healing dynamics. So this is a paper by Carter Rapoli, which basically explain the steps of what really happens when you pull the tooth out. So we have our extraction. Okay, initially when we have our extraction, we get a blood clot that formed in the socket. Over time, in the next week, this blood clot is slowly replaced by granulation tissue. And then after about 2 weeks, the granulation tissue still remains. It's usually at the coronal portion of the socket, while the apical two-thirds, so the bottom of the socket, starts to be replaced with this provisional matrix. This is the initial matrix that starts to create woven bone and then lamellar bone. After about 2 weeks, the hard tissue starts to form. So you start to get this provisional matrix, which will start to form woven bone. So woven bone is basically loose, immature bone. As a woven bone starts to form, it starts to spread from the apical portion up coronally. And during this time, usually within the month or the first 4 weeks, you'll start to see the gingival tissue start to bridge the gap over the blood clot, over the fibrin clot, and over the socket, and you start to get keratinized tissue that slowly grows over and closes the socket. And then what happens in the next 2 months is this bone, you get a hard tissue bridge form over the socket. So we get sort of an opening created periosteum that basically is where the keratinized tissue is then attached, and you get sealing of the socket, soft tissue, and this bridge of bone. And then after 2 months, this woven bone is slowly remodeled and matured, and it is now gradually replaced by a more organized lamellar bone. So lamellar bone is more mature, organized bone. Now, usually after about, usually at more than 60 days, so usually after about 2 months, this bone starts to remodel and you get dimensional changes. So really, this is what we see and what we assume what will happen when the blood clot matures. You get the provisional matrix, granulation tissue, and then the woven bone, the lamellar bone. But reality is, as this process happens, you also get resorption. So as the bone remodels, you get this dimensional change, and you can see now the ridge starts to thin out. The crest of the ridge starts to move slightly lingually or sort of pallidly in this portion, and you get a lot of volume loss on the buccal. So you get a lot more buccal volume loss than lingual. And this basically ends up with remodeling of the ridge, thinning out the ridge, atrophy, and this is what we try to prevent when we do a ridge preservation procedure. Because now what happens is as the bone thins out, eventually the soft tissue will start to collapse and you'll get this little undercut. And now it doesn't look natural, doesn't you lose that volume and contour, and you see deficiency in the ridge clinically. So what happens to this ridge? So what are the exact dimensional changes? So what happens is basically in the presence of a tooth, you get this physiologic stimulation, which is the main factor for maintenance of the bone. But after the tooth is removed or extracted, you get these sort of remodeling and resorptive changes. So what are these changes? The changes are basically the other thing that we know from research is that these dimensional changes, or majority of the resorption and remodeling, happens in the first 3 months after the extraction. So at speed, it's really fast in the first 3 months and then slows down slowly afterwards. So you'll see a lot of these changes early on. You get more horizontal bone loss or horizontal volume loss than vertical bone loss. And the extent of this bone loss is also affected by other factors. So, for example, did you have an elevation of the flap? Was the periosteum relieved? And will you have a full thickness or split thickness flap? If you lifted the periosteum with the flap, then you have a chance for getting a little bit more bone loss and remodeling. The health of the patient, their patient's social lifestyle. For example, are they smokers? Number of roots of the tooth. Okay, so if you have larger sockets, they tend to have more volume loss than smaller sockets. Okay, because a larger gap and a bigger empty space. Also, the the ridge look like before the extract? Was there existing bone loss as well? Was it a thin ridge? Was it a thin tissue biotype? Things like this. So all these factors also play into what may result in more advanced bone loss or minimal bone loss. Now, a study by Schrapp in 2003 looked at extraction site remodeling, and basically they realized that usually you get about 50% reduction in the total width, so the horizontal volume of the socket within the first year. Most of the bone loss occurs, like I mentioned earlier, in the first 3 months. And on the vertical side, we get about a millimeter of loss of crestal bone height was observed within the first 3 months. So remember, you get almost 50% reduction in the buccal and almost a millimeter, so a very small amount in the vertical. So most of this is horizontal resorption that occurs, which we know usually. We usually see buccal bone loss. So we normally see more buccal bone loss, but why does this happen? How come, someone may ask, well, why does it always resorb on the buccal and not on the lingual? Is it because, the buccal bone is thinner than the lingual? And that is in part true. So the buccal bone is thinner than the lingual, but there's something called bundle bone. So when we look at anatomy, the bone that lines the socket walls is called bundle bone. Okay. Now this bundle bone is connected to the PDL of the tooth. Okay. So you get basically Sharpie's fibers and blood supply from the PDL into this bundle bone. And this bundle bone is very thin. It's usually about a millimeter long. Now, in most cases, especially in the anterior area, the buccal plate is about a millimeter anyway. So that means that majority of this bone is bundle bone. So when you pull out the tooth, you disrupt and remove the PDL. And that means that you now take away the blood supply. And so if you have no blood supply to this thin bone, which is usually 0.2 to 0.4 millimeters thick, that this could pretty much represent most of that buccal bone or not. So if this bundle bone now without blood supply resorbs and it's like almost 50 to 80% of that buccal bone, what happens is you get buccal wall collapse. And this is why we see it in the buccal and not in the lingual. And the reason why the lingual it doesn't have this is lingual does have the same amount of remodeling and it also has bundle bone, but the lingual wall is much, much thicker, so it can withstand this little bit of resorption remodeling because it's got more thicker bone, whereas the buccal bone, you see about a millimeter of bone. So when you have thin bone, along with the loss of the bundle bone, you get a lot of volume loss and remodeling. So what have we learned from all these articles on extractions and socket healing issues? So we know that ridge reduction is larger in the molar region, and so it becomes more critical in in the anterior region due to aesthetics. So you get more bone loss or loss of volume in the posterior, but the result is more damaging in the anterior region. And this is mainly for aesthetic demands because in the posterior, even if you get, let's say, as a percentage value, the ridge is still fine, and it's not an aesthetic here, so no one really notices. But in the front, if even a little bit of volume is lost, it's easily seen. So due to aesthetic demands, the anterior is a little bit more critical. And the anterior is made up of thin socket walls, mainly composed of bundle bone, which is a tooth-dependent structure, meaning that once a tooth is removed, PDL is gone, blood supply is gone, it resorbs. And this resorption, obviously, we know, is seen more on the buccal than the lingual. Even though they have equal amounts of remodeling, it's because the buccal bone plate is much, much thinner than the lingual. So this is basically, I've sort of summarized the steps that happen, like the sequence of events that happen and the remodeling that happens once you take a tooth out. So now we know what happens when you pull a tooth out. So what do we do to prevent this? And that is what we call alveolar ridge preservation or socket preservation, whatever you want to call it. Some people don't like the term socket preservation; they prefer ridge preservation. You know what? It means the same thing, so I don't care. Whatever you feel comfortable with, we know that what you mean is to preserve the dimensions of the ridge. So we're going to talk about alveolar ridge preservation or socket bone grafting, whatever you want to call it. Okay, so we got ARP concepts. So what we know is the placement of biomaterials or bone graft into an extraction socket can minimize or compensate for this loss of volume and remodeling that happens when you pull a tooth out. This involves, obviously, you want to minimize the trauma to the bone. Because remember, if you have a very thin buccal plate, you don't want to go ahead and crack that buccal plate or destroy it when you pull the tooth out, because the more trauma, the more remodeling and volume loss. So we want to have an atraumatic extraction. You want to minimize how much damage you do to the existing bone when you remove the tooth. The second part of these ridge preservation concepts is you want to fill the bone or the socket with a bone graft material. Now, these bone graft materials can be various sources: alloplastic, allograft, xenograft, autogenous. We'll talk about all of them, okay? But I'm going to make it very streamlined and simplified, and I'll tell you what I do. And then once the socket is grafted, you have to seal it with something. You have to close it off so that the bone chips don't fall out, they don't get infected, food doesn't get in, and you maintain that volume. So this sealing can be done with a membrane. Membrane can be resorbable or non-resorbable. It can also be sealed with a soft tissue graft. Okay. So if we look at this image, this is from Geislick's newsletter. Okay. This image here shows what you get with the ridge, and then you see in the blue and the green stripes, if you don't graft the area, you get remodeling and you lose this sort of volume. So you see the blue and green stripes are sort of the effects of bone preservation. It maintains this lost volume, and you can see the side is grafted. It's got like some sort of a collagen plug on the top, and this is basically what a socket preservation is. Okay, atraumatic removal of the tooth, grafting of the socket, and sealing of the socket with a plug, and that's it. That is alveolar ridge preservation procedure. Now, there are various modifications, adjustments, and types of material to do. Is, for example, different types of instruments to remove a tooth atraumatically, different types of graft materials that you want to use, and different type of membranes and plugs and socket sealing materials to use. So all these options we will simplify and show. And there's also multiple more. As technology evolves and newer products come, there's always newer things on the market. So if you understand the basics, it'll help you kind of decide what's marketing fluff and what makes logical sense and will work. Okay. So this is from Carter Apoli's article. He again does a lot of research on socket grafting and alveolar ridge preservation and extraction site morphology and things like that. So this is just from one of his publications. You can see here we have a broken premolar. The tooth is not restorable. He atraumatically removes the tooth. He grafts the socket. In this site, he's grafted with xenograft, and then he sealed the socket with a collagen matrix called mucograft. Okay, so or mucograft. It's some sort of collagen bilayer matrix that is used to kind of seal the socket. He lets it heal for a couple of months. This is xenograft, so probably 6 months. He's letting it heal. This is the result. You can see the bone remodeling. You can see the socket as it's removed. Now, one thing I want you to notice, which we'll come back to later, is you notice here you can still see the granules or chips that are there. This is one of the issues when you use a xenograft. And xenograft, sometimes it remodels very slowly. So, there's reasons and situations where you'd use a xenograft, but I'll explain what bone graft I use as my preference, and mostly it's because of the situation here. That doesn't mean it doesn't work. You can use a xenograft, it works. It just means if you're going to use a xenograft, you have to give it a little bit more time. So you got to wait a little bit longer before you go in to place the implant. You can see the implant is placed without issue, and you have vital bone as shown in the histology section there. So this itself is the process of preserving the ridge and getting it ready for an implant. So let's talk about the phases or steps of the alveolar ridge preservation. Okay, so the first step is, once we know that the tooth is hopeless, we are going to make our plan. So the first plan is to do, we have to obviously remove the tooth. So we want to see how we were going to remove the tooth. We got to have a plan. Okay, so we want to minimize this trauma, the surgical trauma that we create in the socket when we remove the tooth. Things like removing bone, expansion of the socket, fractions of the thin bone plates. We don't want to do any of this, so we need to make a plan. So prior to our extraction, we look at the tooth, we look at the radiographs, we look at the anatomy of the tooth, and we look at what restorative stuff has been done to the tooth. For example, is the tooth crown damaged? Does it have something to grab onto with forceps? Is it just a root and bone? Has it had an endodontic treatment? Are nearby teeth crowned? Do they have porcelain? Are the nearby teeth implants? Okay, all these will affect the way you decide how you're going to extract the tooth. Root anatomy is a big thing. Do we have long divergent roots? Do we have bulbous roots? Do you have fused roots? Is it curved roots? How big are these curvature? Because the way a root is curved is the way it's going to come out. As it comes out, it's going to curve in that arch. So you got to understand that proximity to anatomical features like the maxillary sinus, the inferior alveolar nerve, as well as possible ankylosis of the root. So all this has to be evaluated, and you sort of have to make a game plan of how you're going to remove the tooth. Now, there's ways to do that and things that we do and things to make it easier. Okay, so now for single rooted tooth, we usually will loosen the soft tissue around. So basically, the tissue from the gingival margin to the crest of bone is loosened. You can use a 15C scalpel, you can use a periotome, a luxator, uh, or a knife, anything you want to just loosen that tissue. Single rooted tooth are usually removed with luxation using forceps, periotomes, or luxators. Now, I've highlighted luxators here because this is what I use now. I don't use periotomes. I find them a little bit useless now. Once you use a luxator, you just don't need a periotome, and I'll explain what a luxator is. Okay. And usually I use forceps. We use a certain type of forceps. We kind of use a little bit of sort of apical pressure to push in, break the seal, and gently just kind of do rotational movements to slightly elevate and pull the root out atraumatically. Okay. During this or before you get to this point, you can use periotomes or luxators to sort of gently press into the PDL space between the root and the alveolar socket to create gentle luxation laterally to create space to allow that root to kind of luxate and become mobile, allowing elevation of the root. Anterior and single rooted teeth also, you can also section or remove the contact points so that you can then grab it with a forceps and rotate it. Because sometimes they have very tight contacts, and when you grab it, if there's crown there, you won't be able to rotate the root without the contacts hitting or causing some sort of disruption to the neighboring teeth. So you can always then go ahead and remove the contacts, allowing you more space to rotate that root gently without any interference and have it removed. So these are some of the tricks for single rooted tooth. Now for multiple rooted tooth, we want to do the same thing. We're going to loosen the attachment with the scalpel or some of the instruments I said. Now multi-rooted teeth are usually sectioned, okay? Because we want to take a multi-rooted tooth and we want to treat it like multiple single-rooted teeth. So we section the tooth. I always section teeth unless the tooth is really mobile and loose. I don't waste time. I take out teeth fast, and the fastest way to do it is to section it because now I'm taking out three little teeth rather than one big tooth. So they're usually sectioned to separate the roots. I use a surgical drill, meaning surgical drill in the sense that it vents the air not into the mouth. It vents the air through the back of the handpiece, so there's minimal risk of air emphysema. Okay, so a surgical drill. I use a 45-degree angle surgical drill, or you can use the straight handpiece attachment of an implant driller. But I think for teeth, I find those are very hard to get in. It's a really large handpiece, so it's easier to just use a 45-degree angle surgical drill with the rear venting. And then I usually section my teeth with a carbide burr. A 702 surgical length is my go-to burr. Sometimes if it's very narrow or thin, I'll use a 701, but 701s are thin and they're used for just slight adjustments around a broken root. So I prefer 702 because less chance of the burr breaking, and it's a thick workhorse. So the 702 is my workhorse burr for sectioning teeth. If they have any prosthetic crowns, I will usually cut and remove them first. So I cut and remove the crown, and then once I have the prosthetic crown off, then I will do two things. Now you can either section the entire anatomical crown off and then section the roots to luxate and remove them, or you can just go from the prepped crown and just section the tooth and lux the roots out. Some people find that when they cut off the crown, you can get in deeper to section the roots as well as get more space mesially and distally so you can kind of luxate and wiggle out the roots. So it both ways work. Sometimes if I feel like I'm getting resistance or the crown's too big, then I'll shave or cut it off and just section the roots. So it depends on the case. Each root is luxated and removed as a separate single root. And sometimes, if you need to, if you're having issues trying to get a root out, it's not a big deal for you to go in and section the septal bone in between. Because remember, when you have a socket, you can remove the bone within the socket. You just don't want to remove the outer walls of the socket. So you don't want to damage bone at the mesial, distal, palatal, and buccal wall. Everything else in the middle, it's fine because you'll end up with a four-wall defect, which is a socket which is going to regenerate quite easily. So don't be shy. You create space within the tooth itself, so within the socket, so you can luxate and push things inwards rather than pushing outwards laterally to the walls where you want to preserve it. Okay. These are my three main burrs. Okay. This is a Brasseler long shank diamond burr. I use this to go in and if let's say I get a broken root tip, this burr is extra long and thin. It can go in and remove a little bit of bone around the root tip to allow me to gently luxate it out. The burr in the middle is a 702 surgical length burr. This is my main cutting burr for sectioning teeth. And the burr on the bottom is a 701. This also is then used sometimes to create little grooves around the roots or to remove some septal bone to allow ease of luxation and elevation of the root. Here's just what the long thin burr looks like on a handpiece. This is a surgical handpiece that I use. I use a Brasseler surgical handpiece. Uh, you can see the length of this burr. It's nice and long and can easily get in and around, and it's very thin, so you can kind of remove bone very easily without doing too much trauma to the surrounding walls of bone. Here's our 702 burr. Another view of it, so you can see this is a rough, aggressive carbide burr, which cuts roots really nicely, cuts like butter. Okay, same thing. This instrument is a luxator. So a luxator is like a straight elevator that thins out to the end. So it's almost like a straight elevator and a periotome at the same time. Now I like these because look how thin they are. The blade gets really thin, but it's very strong. It has a handle like an elevator, so you can actually put more force. With periotomes, they're flexible and thin. To me, I felt periotomes really didn't do much. They kind of pushed and pushed, but I felt like I was just wasting time it took forever to kind of loosen it. So once these products came out, now this they're called luxators, so it's almost like a combination of a straight elevator and a periotome in one. And you can see how they have this very thin beak. Now this has a lot more strength and force to it, and because of the handle, you can push a lot more force, and you can force this down a root and really put some pressure and get that tooth moving. So I now never use periotomes. I just use these guys. Okay, and literally I have two of them. I have this one and have a thinner version to get into smaller broken root tip. And that's it. Okay, so this is another view so you can see how thin it is. Okay, so this is my go-to. So one of the pearls for today is look into these luxators. The brand that this forcep is and the ones I use are called Luxator brand. They're the originators. But now if you look up luxators, many extraction equipment companies carry these. They're sort of copies of the same instrument, okay? But or you can get the exact one with these, which is called the luxator. So okay, Luxator. Now the other one of my favorite instruments to remove roots after I've sectioned them. These work really well for molars, mandibular molars. Usually when I go in and I section a mandibular molar in half, I will then take this instrument and it's almost like a crier and a straight elevator mixed in one. So if you look at the tip has a curve in it. So this little sharp point engages, and there's a left and a right because one turns left and one turns right. So if you look at it, it's got this curve in it. And this curve is like almost like a mini crier that hooks onto the root. And as you turn and twist this, it will almost create a luxation and an elevation motion at the same time. So it's almost like a mini crier. Okay. And then obviously our next instrument is our criers. So usually what I do is I use these instruments to go in and remove or elevate root tips. They kind of engage the root and kind of elevate it straight out. So it's really good. My go-to for for example, a molar extraction, like I remove the crown, section the tooth in half. Once it's sectioned, I stick one of these in. I will luxate. They usually kind of pop right off with these. If they don't, I can use my luxator or I'll go to the criers to just pluck the rest out. So these are criers. Now for criers, I use mini criers, not regular criers. Regular criers, if you've ever used them, they're really large and they're kind of useless. They're like so big that when you try to go in and rotate, it just feels like it's just pushing against the socket wall. So the other version, so you get regular criers and you have mini criers. I use mini criers and I suggest you should just only use mini criers. They're smaller and they can get in and engage the root tip and you just twist and it just luxates and pulls it right up. Okay. So mini cries is my other two. I very rarely use these because most of the time the luxator instrument and those curved little combination crier straight elevators, those golden ones that I just showed, those work well, and I really never need to go to these. To be honest, majority of the time, 80% of the time, I just use my sectioning burr and my luxator instrument, and I get the root out. Sometimes I'll use the golden handles, but the golden handle ones, those golden tip ones, I only use in molars, mandibular molars really, and very rarely I'll have to pull out the crier. Okay. Now the other thing I do is forceps. Now for these atraumatic, because I'm sectioning all my teeth, I usually section all of my teeth. I use these forceps with these beaks. The forceps, now you can get these as a universal upper and a universal lower, and then there's anterior for maxilla and mandibular. They have these small little teeth and beaks, so it can go in and grab the root and allow you to have a good grip so you can sort of luxate, twist, and rotational movement to get it out. Now, these are good because remember, we're sectioning our teeth and then we're taking out each tooth as a small single rooted tooth. But they work great for all cases, and these are my go to. These ones specifically you can get from Salvin, okay? They're basically a traumatic extraction forceps. You'll see they have this small little beak at the end. Okay, you can see the little beak right there, and then you have a nice grip on them. Okay, so these are my go-to forceps, and I just really have a universal upper, universal lower, maxillary anterior, and a mandibular anterior, and that's it. So 4 forceps is what I do. So my armamentarium is very small. Now I want to talk about the concept of bone walls and regeneration. So remember how I said a socket is a four-wall defect. So if you look at these, this is a periodontal diagram for periodontal defects. So if you look at these 1 wall, 2 wall, and 3 wall defects, the more walls you have, the more predictable you can regenerate the bone. So these are periodontal defects around roots of teeth. So you can see the most predictable is a 3 wall defect because you have buccal, lingual, and the mesial or proximal wall. Now a socket has a third wall, a fourth wall. So sockets are even more predictable. For if you have 4 walls and the socket is intact, there's no reason why you shouldn't be able to regenerate the bone to the level of the socket. So hence, when I mentioned when you're sectioning teeth, you can cut into septal bone and remove bone within the socket because if you have the walls of socket that are intact, it doesn't really matter if you remove the entire septum, you're going to be able to regenerate that easily. So when I'm removing a tooth, I'm not too concerned about removing septal bone. I take my drill in and I just go boom, 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 cut, 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 cut enough bone, give myself space to luxate because I'm going to luxate now the roots inwards into the space I've created from my sectioning. And then I elevate and pop, 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 they're out. So literally, once I section that tooth, it's like under 2-3 minutes, the tooth is out, clean the socket, and we're done and we're ready for grafting. So by not being shy with the drill and knowing how to use the drill and how to section, you make your life so much easier and the tooth comes out so much faster. Nobody wants to sit there for like 5-10 minutes luxating back and forth with the forceps, loosening it, right? This is just in and out, like 5-10 minutes, tooth is section and done, and you move on to the grafting. So here is just an example. You can see we have our crown. There's a molar, maxillary molar. Notice how I've sectioned off the crown in the first image on the upper right side. So we sectioned off the top of the crown. Now from here, you can see we just have this lower crown. So the contacts are gone. We have more space. Now all I do is I do my Y shape. I'm sectioning the tooth with my 702 burr into 3 separate roots. And then I take my luxator and I literally luxate. When I luxate, I push the sockets inwards into the space and they loosen, and then we elevate and lift each one up. And literally in a few, literally 2-3 minutes, the roots are out, and here we go. This is our socket. For molars, same concept, just different way of sectioning. Here we remove the crown. Crown is removed. I section the tooth in half, and then here's where I use those, either the luxator or those golden instruments, and we kind of stick them in, luxate, elevate, and it hooks and lifts up. Take one root out, and we take the other root out, and we have our socket. Okay, so this is literally the way we do mold teeth. And obviously, anterior single rooted teeth, we just grab onto the tooth, rotational forces, gentle luxation, rotational forces, twisting rather than pushing buccolingually, and it just pops right out. Once the tooth is out, we examine the socket. So we want to clean out the socket. Okay, if there's a lot of granulation tissue, you got to remove all of it. When there's a granulation tissue, it's going to keep bleeding and oozing. So if you notice an infected socket that keeps bleeding and bleeding and bleeding, you gotta just get in there and scrape all that granulation tissue out. You'll notice as soon as that granulation tissue comes out, all of a sudden the bleeding stops. It gets much better. Okay, so I prefer serrated curettes for these because it can clean the socket better, and the serrations also will create bleeding in the socket wall. If a socket is severely infected, normally I rinse all my sockets with sterile saline. If a socket is very, very infected, then you can rinse with a 0.12% chlorhexidine solution or an ANSEF solution. ANSEF is a antibiotic cefazolin. Usually I'll mix, if I can remember, I think it's 1 gram, so it's 1 pill, 1 gram of the cefazolin powder. You mix it with about 20 cc's of sterile saline, and that gives you your ANSEF solution, and you will squirt and irrigate and flush the socket with that. And this is sort of for really infected sockets. We then, once the socket is cleaned out, I'll then examine the socket itself. We'll visualize it. I'll check with the curette by feeling the walls or a probe, and we'll make sure there's no fenestrations, dehiscences, or breaks in the bone. And we notice where the bone is. And then based on this, we will decide how we're going to graft it based on the amount of bone loss. And once we've done this you want to get the socket to bleed, okay? Because if you don't have any bleeding, then you're risking having issues with healing. So I usually will scrape the socket with the curette. And if that doesn't work and you're not getting inducing bleeding, then you can make small micro perforations in the bone to induce some bleeding. I usually use that long pointy diamond burr that I showed that will then just make small little perforations just to induce some bleeding to get the remodeling phase started. So now that we have our socket prepared and ready, we're ready for our bone graft material. So with regards to bone grafting, what bone do we choose? So I'm going to make this very simple for you. Okay, so there's different types. So most sockets are grafted with either allograft, which is a human source, or xenograft, which is a different species source. The most common xenograft is bovine, so a cow bone. So allografts can be either mineralized or demineralized. Studies have shown that FDBA, so mineralized, resorbs slower and acts as a better scaffold than demineralized. So for mineralized cortical or cortical cancellous is the best choice for a good scaffold and good turnover for bone. This is my ideal choice. I use cortical cancellous allograft or cortical allograft. Both work really well. The reason I use it because it turns over faster than xenografts. In about 3 to 4 months, I can go in and place my implant. Whereas xenografts are much slower resorbing than allografts. They take a lot longer. They're shown to over time hold the volume with better dimensions, but it also takes a lot longer to turn over and sometimes years, and you can still see particles in the bone even after a year. This is usually not my first choice for a socket preservation graft, but it can be done. If you use it, then you're going to wait at least a minimum of 6 months before you place the implant. If you're not placing an implant, and let's say you're doing a pontic site or something, then you could use it. That I may tend to use xenografts if I know that there's never going to be an implant. There's going to be a pontic site for a bridge. Those cases, then, or it's going to be, or the patient's going to wait a really, really long time before they place the implant. Then I would be more inclined to stick with the xenograft. And then lastly, we have alloplasts. Alloplasts are synthetic grafts, so these tend to resorb much, much slower than both the xenografts and allografts, with the exception of calcium sulfate. Okay, calcium sulfate grafts resorb or turn over really fast. They work well. You can place an implant in 3 months. They're just like a powdered putty. And so I feel that sometimes if the socket is not fully intact, it, to me personally, I feel like it just doesn't hold enough volume and maintain the volume to keep that volume of the ridge when it resorbs. The other common ones are hydroxyapatite and beta tricalcium phosphate. These are also very slowly resorbing. I don't recommend them in sockets where you're going to place an implant. It can be used for a pontic site. If let's say you have a patient that insists that no, I want synthetic bone, I don't want to use an allograft xenograft, then maybe you can lead them towards calcium sulfate. Or if you can use hydroxyapatite or beta tricalcium phosphate, what I do is I tend to mix it with autogenous bone scrapings to help increase the turnover and osteogenic potential of the graft. So this literally summarizes bone grafting for you. Remember, if the patient is okay with it, my go-to and my key one is allografts. So hopefully this kind of gives you a little bit of a decision tree. Now, the bone graft of choice, like I said, is mineralized cortical cancellous blend, which allows me to place implant in 3 to 4 months. The graft material itself is hydrated with sterile saline, and then it's packed into the socket in small increments with either the socket curette or a bone curette and bone packer plugger. I sometimes, to make life simple, I use the socket curette to pack in the bone, and and then what I use sometimes is a simple way to use a bone packer. It works really, really well, and it's already in your surgical kit. So I use the end of your scapula. So a round scalpel handle holder or a thin mirror handle is used as a packer, and you can use that to pack the bone tightly in once you insert it with the uh, curette. And a little diagram on the right side shows you on average. For me, on average, I use about 1 cc for molars, and then for anterior teeth, sometimes laterals, 0.5 cc. Canines are usually 1 cc. Bicuspids are usually about 0.7 cc, so or 0.5 cc if it's a really small one. So on average, I usually will pull out a cc of bone for most cases, unless it's a very small root like a lower mandibular incisor. Here's just an image of the socket curette with bone. So I literally use these to just slowly pull small increments of bone and pack it. And then sometimes, like I said, this is a scalpel handle. You see the back end of it. The back end of it is perfect for packing bone. So I'll usually just take the blade off for safety. I'll slowly incrementally pack with the curette, and then I'll use this to go ahead and compress and pack it tight and tightly. So this is our bone pack. Now socket sealing. So now that we've got our tooth that's removed, we've sealed this, we've packed the bone, we're ready to seal the socket. Now membranes are used to seal the socket in ridge preservation procedures. They can be both resorbable or non-resorbable. If the walls are intact and everything is perfect and the socket is good, then sometimes something as simple as a Healy plug or a simple collagen plug, $10-15 can be used to seal the socket. You can sometimes use a product called Mucograft Mucoderm, which offers a similar result as a collagen plug, but it's much more expensive. So use the Healy plug; it's cheaper. It works the same way. You can also use non-resorbable membranes like a PTFE membrane. These are products that come from osteogenics or cytoplast. It's a dense polytetrafluoroethylene membrane. They're tucked into and around the socket to seal the opening. These can be left exposed. They have to be the dense version, but they do require removal, and usually we remove them at about minimum of about 4 weeks time. And socket sealing lastly can be done with autogenous tissue, connective tissue from the palate in the form of a pedicle connective tissue graft or a soft tissue plug to seal the socket. And usually with these soft tissue grafts, we tend to use them more for anterior aesthetic zones where tissue volume is important. So here we have an example of a plug. This is a collagen plug packed into the socket and sutured in place. Here is a mucograft. Okay, this is again the more expensive collagen material. But again, like I said, from what I've seen, a Healy plug and a mucograft plug or a seal, they work similarly. I haven't found a huge difference in the healing. Here is the PTFE membrane, the non-resorbable cytoplast, dense PTFE membrane. Here you can notice that it's tucked both on the buccal and the palatal and then sutured in. These work really well, but you have to tuck them in tightly so there's no mobility of this. And then you suture over it to hold it in. Here is a pedicle graft. Okay, so this is a pedicle graft in the palate. It's slid over through the socket, and you can see the stitch where it's secured. It's tucked into the buccal and secured in. This will seal the socket. At the same time, it will give you more volume. And then this is a soft tissue plug. So this is almost like a mini fusionable graft with the thicker connective tissue layer, which plugs and seals the socket and secured in place. So these are a few options for sealing the socket. I tend to use soft tissue more in the anterior region, and we use PTFE as my main go-to for the posterior region. And sometimes if it's very small, like for example premolar site, I'll tend to use a collagen plug. So how do you decide how to approach a socket graft based on the possible, results of the socket or the possible bone loss of the socket after the tooth is removed? So an easy way is to have the simple socket classification, which was published by Marius Stegman and Homle Wang in 2022. And so here they've classified sockets as SD1, SD2, and SD3 ABC. Now SD1 has two portions, which is A and B. If the buccal bone is very thick, they tend to leave it and not graft it. Okay, so here's our decision tree. So for SD1 is where all the bone is intact. So buccal bone is intact. If it's a very thick buccal wall, They just put a collagen matrix, or they don't even do anything. And in part B, you have a thin buccal wall, and in this case, they graft it with the bone, so allograft, and they do a kernel plug or a seal, which is maybe collagen. I personally graft all my sockets if I'm going to graft. Doesn't matter how thin or thick they are. So for me, I always graft. So for me, SD1 is one classification. It's just grafting. It's a straightforward, intact socket. I graft and seal the opening of the socket. Okay. SD2, we basically, this is where you have a buccal fenestration. So here, I will use what's called an ice cream cone technique, where we slide in a small resorbable collagen membrane. You can do it also with non-resorbable cytoplast or PTFE membrane, but it's shaped like an ice cream cone where the V shape slides down the socket into the socket between the flap and the socket, and patches or covers the fenestration, and then you have the circle, which is like the ice cream part, that seals over the top of the socket and closes up. So this is for a buccal bone with fenestration. And then we have SD3 classification. Here's where we have buccal bone loss. So we have buccal bone loss in three severities. We have STA, B, and C. So a third or less than a third is STA. Between a third and two-thirds is STB. And SD3C is greater than two-thirds. So for something where you have just a little bit of bone loss on the top coronal portion, we can use something like the ice cream cone technique to graft. If it's larger, we then will use a graft that can be used either stuffed in through a tunnel and grafted like a GBR approach, or we have to, for large dehiscence, so ST3C, we almost have to lift an entire flap and really graft more volume both into the socket and outside a little bit of the socket to get more volume. So this is my decision tree. So let's look at a few cases of each of these variations of SD1, 2, and 3, and we see how we treat them. So we'll look at some surgical cases and I'll show you. Now, these are just a few different cases treated differently. Just I put some interesting cases there because sometimes socket preservation grafts are a little bit boring from a case point. So I tried to add a little bit more so you can see how we use different materials and soft tissue grafts and use GBR approaches as well. So we're going to start off with our SD1 case. Our SD1 cases are basically your ideal simple extraction socket preservation graft. These are done with just simple soft tissue plugs or seals. So here we have our molar. The tooth is removed and section removed. Tooth is debrided. The graft is cleaned and scraped out. Okay. It's then grafted with, here we have corticocancellous allograft bone. So we've grafted to the top of the socket. And then here, I'm going to use my PTFE membrane. I want you to notice how I've kind of trimmed and tapered one end. And the reason why I taper is that tapered thinner end is then used to stuff down the buccal side. So we create a little buccal pouch, and then that thinner end is stuffed and pushed down the buccal pouch, and then it's flapped over and tucked into the paddle portion here. And then we have this suture. This is almost like a horizontal mattress suture, a continuous horizontal mattress suture that will then seal and hold this membrane in place. And this is basically a simple socket preservation procedure. Now, these sutures and this membrane are left in for 4 weeks before everything is removed. And by then, you've epithelialized and sealed the socket, this immature soft tissue covering it, and it'll just mature and crack nice. So here's our basic steps. And this is a straightforward, simple socket preservation with PTFE membrane. Okay. Now these membranes are dense PTFE. They're meant to be exposed like this. You just have to keep them clean, and as long as there's no mobility in the membrane and it's tucked in nicely, you will get a nice result. And I find these are really, really good to maintain and get nice amount of bone. Now another case, here's a premolar. You can see a fracture in the tooth and decay. Tooth is removed in 2 pieces. Okay. In this case, we removed the crown, we luxated the root gently, and then elevated and removed the root tip. The socket is then debrided and cleaned out with the curette. It's grafted with allograft bone, packed in nicely. And then here we have a Healy plug. So it's a collagen plug, which is then compressed over the socket. We then put some sutures over the socket to hold it in. And then I use a little bit of tissue glue to just dab a little bit to just seal up the opening, because I want a nice watertight seal. I don't want this collagen kind of fluffing us. So whenever I use the collagen, I tend to sometimes use a little bit of tissue glue to get a nice watertight seal over the socket. And that's it. Here's basically the tissue glue. We usually use a little micro pipette to just put small little drops onto the Healy plug, and I kind of just dab it with some moist gauze to just allow it to harden without sticking to things. And then that's it. So that's a straightforward, simple case. Tooth is removed, and we use a Healy plug to seal the socket. Here's our third case, and we saw some of these images before. Tooth is sectioned, each root is removed separately, socket is debrided and cleaned out. It's grafted with allograft bone, and then we use our membrane. So remember, for molars, for maxillary molars, we tuck it into the buccal first, and then we flap it over to the lingual for and then tuck it in. For mandibular molars, I'll tuck it into the lingual first, pack the bone, and then I will fold it over and tuck it into the buccal portion, and then suture and close it. Okay, here's a little bit of a more complex or fancy type of suturing technique that we developed, and this will hold it in. It's almost like a little net to hold the graft in. And this is after the membrane has been removed. After a few weeks, you can see how it's sealed and keratinized. When we elevate the bone, elevate the flap, you can see the bone is nicely remodeled. And this is at 3 months. So we can see at 3 months, we got a nice solid ridge. We can go ahead and place our implant. Okay, adequate bone for the implant and tissue. So now you can see we have adequate tissue volume, adequate bone. Implant went in without an issue. Okay, so this is a straightforward, simple posterior ridge preservation implant placement. Okay, it doesn't get much easier than that. Now, in some cases, remember we said we have a buccal fenestration. So this is what we call the ice cream cone technique. If you look at the shape of the membrane, this is a collagen membrane. It almost looks like an ice cream cone. So you have the ice cream and then the cone shape. So this is where you have a small buccal fenestration. Here, because of the fracture of the tooth midway, we end up with a small buccal fenestration. So once it's cleaned out, we then will create a little pouch on the buccal. This is stuffed in between the periosteum and the soft tissue to seal the fenestration. We graft our bone, and then you can see here the bone is grafted, allograft, and then you see the top part, so the ice cream part of the membrane is then pulled over the socket, and then with a little suture, it's just stitched and held in place to secure it, almost like a little flap. And then in this case, we just took the same tooth. I adjusted the shape of the crown and made it like a pontic, and we bonded it back to the wire. And he used this as a temper. So this is what we call the ice cream cone technique. Now this can be done with a collagen membrane. If you use a collagen membrane, I tend to use a stiff collagen membrane like OsteoGuard because it can get pushed in. Whereas really soft membranes, when you try to push them in, they'll just roll and fold up. So a stiff membrane like an OsteoGuard will be nice for these type of cases. You can also use the cytoplasm membrane, the non-resorbable cytoplasm membrane, which is basically what we use in some cases, but in this case not. So both cases we can do this, okay? Both types of grafts. Now when we look at ST3, so ST3 is the ones now, this is the third segment, and these are ones where we start to see a lot more bone loss. This is where now ST3A is where you have bone loss at the coronal third. Okay, so you have a dehiscence at the coronal third of the graft. Here you can see it. Now this is an anterior case, so I'll show you how we manage this. One of her complaints was that if I'm going to be losing these teeth, I want to make sure that when I get my new teeth and the implants, we're going to try to maintain this soft tissue and these little papillas. The good thing is the papillas aren't very high right now. They're short peaked, so it's easier to maintain. And so teeth are removed, all atraumatically. One of them was a pontic. Okay, so it was actually a cantilever restoration. Teeth are debrided and cleaned out. Because of that one area, we had some bone loss. So here again, it's a stiff OsteoGuard membrane. It's stuffed into the socket on the fascia. I then will graft allograft bone. So you can see here the contour of this because of the stuffed membrane, and we push out a little bit. So we graft all of these areas with allograft bone. Now where the pontic site here, I wanted to get a little bit more soft tissue volume here. So I made a small little tunnel. So we make a small little vestibular incision and we create a tunnel in space. The connective tissue graft is then pulled in through this tunnel to lie in this area with purse string sutures. And it's secured in place. So you can see now that dip looks much more wider. So now we have our grafts and dip. So now how are we going to maintain the volume here? Okay. Now the way we did this is we chose to, she didn't want to do soft tissue grafts. So and she had enough volume. So all I needed to do is keep some sort of collagen material there and have the volume maintained with ovate pontics. And we did this through an Essex retainer. So here first, I used the rest of the collagen membrane to just use as sort of little discs as patches to sit over the opening of the socket. Then we took mucograft. So this is the collagen material, which is then stuffed over those collagen membranes. And this is what we use to tent and create that volume. Okay, so we use the collagen sponge type material to kind of use to fill and tent the shape. And this is secured in place. If you look at the ridge volume that's maintained from the facial, you can see that we've maintained support of the papilla. Now I'm going to take the S6 retainer. Here you notice how I asked the prosthodontist to give me a little bit more additional contour to create ovate pontics, which will then press into the soft tissue and the mucoderm or that collagen sponge to help maintain pressure and shape of the papillas. Okay, because remember, we're taking out all four of the teeth. I don't want these papillas to collapse. Okay, so this is the patient after 2 weeks. You can see the shape because she's wearing the Essig retainer. The shape and the papillas are being maintained. Okay, you look at it from a coronal portion. At 2 weeks, you can see we still got this mild architecture of the papillas. Here you can see how it's nicely fitting nice and snug in and around the teeth. And then we give it a couple of months and this is what it looks like. So you can see it's maintained that nice soft tissue volume. We have the nice shapes and peaks of the papillas. So we've sort of maintained the papillas through using this approach. And it's a very simple approach. It's just done in a layered fashion. Okay, so that is our SDA. Now our SD3B, this is when you have about a third to two-thirds bone loss. Here, you can see we have a fractured root with a lesion. The root is luxated and removed atraumatically. Here's when we evaluate the socket. We notice the buccal loss of bone. So we take our collagen membrane. It's stuffed into the site. Okay. Once it's stuffed in to sort of create the wall, we then use allograft to pack into the socket. Here you can see the entire socket is packed with allograft. And now, because this is an anterior case, we want to keep that volume of the anterior volume. Okay, so we want to keep that contour because we want to make our result look in volume and shape like the neighboring central. So we use a pedicle connective tissue graft. So here you can see the pedicle itself is taken from the palate. I make an incision here and it's tucked in through this little incision, so it's coming over the socket, and then it goes into the buccal and gets tucked into the buccal and secured with a purse string suture. If you look at the palate, you can see my incision is made here like this, and then this bridge of tissue is elevated so that the graft can kind of come here, and the graft is still connected to the tissue on the palate. That's why they call it a pedicle. So we take this tissue and it's still attached as a pedicle, slid through this area here underneath this tissue, and then slides over the socket and then gets tucked into the facial. And then we take the partial, I adjust the partial a little bit, and you see how it nicely sits in snugly into the socket. So the partial itself is pushing volume and helping support the papillas. This is a removable temporary partial denture, by the way. We see the patient basically at 2 weeks, and you can see we've preserved the volume and shape. You can see we've got ample volume and tissue shape. And then this is sort of as the site is matured before it's ready for the implant. So you can see we've got all this volume. When you compare it to the neighboring tooth, we've got so much volume that now we can place our implant, and then when we do the provisional, we have a lot of tissue to now shape and get papillas. So we've got all that volume preserved and maintained through that simple preservation procedure. Now, when we look at the last, I guess, classification or segment is SD3C. So now SD3C is when you literally are missing a lot of the buccal plate. Okay, all of it, and then you sometimes can even have vertical bone loss. Okay, so I'll show you one case here where we have all of the buccal plate missing and how we address it, and then I'll show you in the last case, which will be where you have a little bit of vertical bone loss. So here the tooth is removed we elevate the flap because once I remove the tooth, I realize that there's no buccal plate. And here you go. So here we can see literally most of the buccal plate is gone. So in this case, it's treated like a GBR procedure. Okay. So we graft the area with allograft bone. You notice I'm grafting past now. This is like a GBR. So I'm grafting past the alveolar envelope. So I'm grafting more bone outside the skeletal envelope. We then use a membrane, a collagen membrane in these cases because I don't want to open the flap again. So collagen membrane secured with this suture to hold the membrane in place. These is a non-resorbable suture, but the knots are all tied on the outside of the palatal flap, so they can easily be removed after a month. Okay. If we look at another view, you can see now the bulk and the contour that we've built up from this. And then the flap is then closed over. Now you can also add an additional tissue graft if you want in these cases, or you can close it up. Here we close it up, and then we use our existing crown and we just splinted it in place with just some bonding, just so she could have a tooth in place. And then this is just, we did it kind of fast. She's going to see her restorative dentist and get it bonded a little bit better and more ideal. So this is how I would treat a case as a GBR procedure. So some, unfortunately, some extractions end up like GBR procedures because of the extensive amount of bone loss. Now here's a cool case. I just did this case actually a few weeks ago. This is a patient. He was a smoker. He had, obviously these teeth that have been losing bone. He had a loss of velar bone and also vertical bone. So when I decided to graft this case, I knew that we'd have to graft some vertical height of bone as well. Both buccal and lingual walls had missing bone as well as loss of vertical height. So I removed the teeth. Obviously, these teeth are, they pop out easily because there's not much bone holding them. We debride and clean the sockets, and then I elevate my flap. Here you can see the extent of the bone loss of the sockets. Now, ideally, when I graft, this is going to be future implants. So I want the bone to get back to this point here. But you can see if I draw a line here across, there's missing buccal and lingual walls, both in volume and vertical defects. So in this case, we have to use membranes to create walls and to close the case. So I'll show you how I treated the case. So first, I put a lingual stiff collagen membrane to create a lingual plate. Okay, then we put a buccal membrane. This is OsseoGuard. Okay, this is OsseoGuard. It's a very thick membrane. So OsseoGuard, it comes from Zimmer now. I think Zimmer Dental owns OsseoGuard. Okay, so we got a buccal and a lingual plate. So we recreated our plates. So if you look at it from a different view, now you can see we've recreated the plates to the height of where we actually want the bone. So now that I've recreated these plates, now I've created a trough, and in this trough, I'm gonna fill in my bone graft. So I fill in my allograft bone. Okay, the allograft bone is filled in, and now to close over the top, I will then use a different collagen membrane. So here's another view. So we've basically created two walls with our stiff collagen membranes grafted to the top, and then here I use a drapable collagen membrane that drapes over the top of it. So this is BioGuide. Okay, this is the BioGuide collagen membrane. Now this drape membrane is then draped over. Now I want to keep this secure because I've sort of made these walls and I've held everything in place. I don't want this to fall apart. So in order to keep it secure, I use sutures. So here we have multiple sutures going from the buccal to the lingual to secure and hold my membranes and my graft in place. Okay, the more rigid and secure they are, the better my chances for getting a nice amount of bone graft regeneration. So here's just a buccal view of it. Same thing. You can see how the sutures are holding the graft and all the volume nice and tightly in place. And then the flap is released. And because he was a smoker, we chose to get primary closure. So we released the flap and closed up the flap. And so by closing up the flap, we minimize the risk of having any infections or issues and loss of bone from the ridge. All right, guys. So I'm going to bring Stephen back on for a special announcement for you guys. Stephen, are you there?
I'm here, Nahid. That was awesome. Everybody stick around. We have a lot of great questions for the Q&A. But first, I'd like to make a special announcement that today we are relaunching the Extraction Socket Grafting Masterclass. We offered this as a charter membership offer last year, and then we built the course, but we haven't been offering it since. So we decided we're going to offer it now with this webinar. And we call this ESG. You might see it called ESG in some places. And basically, if you want to start offering more difficult and different types of extractions and socket grafting in your practice, this course is for you. This online course is for you. You don't have to leave your house or your practice. You don't have to fly anywhere. You can watch this at your own pace and learn it on your own time. And with the extraction socket grafting masterclass, we've designed the curriculum to teach you the step-by-step systems to manage basic to complex extractions and socket grafting procedures. And the extraction socket grafting masterclass, as I said, is an online course. It's an online masterclass. So you don't have to go anywhere. It's all on your computer in high def, beautifully recorded videos that Nahid has created. We're still adding some videos to the extraction portion of this, but the rest of it is amazing. Looks like so well done. And if you're offering dental implants in your practice, I'd say that this is a must. The ability to create a beautiful ridge from extraction sites, especially with defects that you can then go back and place implants in, is invaluable. And so there's been a link added to the side of this page in the webinar jam control panel. And it's basically failingdentalseminars.com/ESG online WJ. So just like this, but there'll be a link popping up that you can click on. And here's the portal of the membership site. Everything's completed now. We're going to add a few more videos here and there, but it's all essentially there for you. And I'm going to have Nahid describe the modules. First module is called Socket Preservation Concepts in Biology. And why don't you tell us about this, Nahid?
Okay, so module one is starting off with the basics. We go over the concept of extraction socket preservation. We go through the healing and biology of what happens to a socket once a tooth is removed. We talk about why it's important to do a bone graft in the socket or a socket graft, and how it benefits for in the sense for aesthetics, for prosthetics, for implants. We also talk about types of sockets and give you a classification system on how to treat different sockets and why we do it that way, as well as different materials that we use. So this is sort of like an overview of the basics. We kind of develop the foundation of socket preservation here, and then we kind of take it into the further deeper modules to go into more detail with specific types of extractions. We go over things like the types of extraction, then different scenarios where anterior cases, GBR case, which we're going to talk about in a second.
Yes, and you showed, I believe, some case studies in this module too.
Yeah, some of these, you'll see some of this stuff in some of the you saw in get a taste of it in the webinar, and we go over some cases in this module as well, just so you kind of see what we talk about basically from a theoretical point and through concepts, and then showing it in a clinical example.
Excellent. And then module 2 is about extractions, basic instrumentation, simple and complex extraction techniques. And so take it away. Let us know about this, Nahid.
Yeah, so this is one of some of our members our favorite module. This is the one module that you'll kind of really take a lot of pearls and use this in your practice immediately. So this is our basic extraction module. It goes over the basic instrumentation that we use for extractions. We go over simple extractions, complex extractions. Uh, this is sort of like our basic foundation. Okay, this will give you your concepts for what you need and how you remove a tooth, and then we go over things like what I do to sort of streamline my approach to taking out teeth. We go over sort of some key points to tell you how to take out any tooth in the mouth apart from impacted wisdom teeth. We go over my simplified sort of instrument tray, and then we talk about things like how to do it, traumatic extractions, how to really get confident and fast at removing teeth. And sometimes these are sort of nightmares for some dentists where they're always scared that they're going to break a root, the root is curved, or the root tip is going to get stuck. So we talk about how to deal with things like this and how to feel confident no matter the outcome, whether you have a full tooth that comes out in one piece, or you have to section it, or you break the tooth and you're trying to take out roots or root tips out of the socket. So we show you how to do it all, and we make it very simple so that you can sort of take the knowledge and the next day you're out there applying it in your clinical practice.
Yes, this module, I remember you shared some complicated extraction techniques or cases in the posterior, some
Yeah.
difficult posterior cases, which is helpful for everybody to see how you got out of them too.
Yeah. Well,
The
we
next,
what I
sorry.
was going to say is that all these modules, they do have video in them as well. So you'll see photographs and then you'll see live video of extractions and the procedure. So you kind of get to see it from, learning about it theoretically, learning the basics through instructions, and then seeing it in photographs and then surgical video as well. So you kind of get the complete sort of circle. And this is what sort of allows you to really learn and pick up most of the stuff, even though it's still an online course.
Yeah, there was a lot of good surgical video in this module. Next is socket preservation bone grafting techniques.
So yeah, so this is module 3. So we've talked about the foundations and the biology and the basics in module 1. Then we talk about extractions in module 2, and now module 3 will focus on the basic conventional socket grafting or socket preservation approach. And so here we talk about, you know, the socket grafting or the bone grafting procedure for a socket. We talk about how it's done, sort of the basic step by steps of, going from removing the tooth to cleaning the socket, how I insert the bone, how you kind of seal the opening of the socket, whether it's done with something like a plug or a membrane. We talk about different ways that we seal or suture the socket. So again, this goes through the conventional basics of a socket preservation procedure, and then we show a few different approaches and techniques using different materials. So you kind of get a complete scope of socket preservation itself.
Amazing. What I really liked in this module when I watched it, I did like the clinical cases, the case videos, but the best part was when you did the all the different techniques and suturing techniques on the model you filmed in your microscope. That was the step by step, exactly how to move the needle and where to put the needle, where to suture. It was really, really good, actually.
Great point, Stephen. Is when I show certain steps on a model, you get to see it with a lot more detail and from different angles that you may not actually be able to see in a live clinical surgery, because then there's blood and things like that. So we go over every aspect of the actual procedure. We break it down, and on a model, you're able to do that. And you get little things and tips that I do, and you can actually see it clearly, and I can teach it more easily. So a lot of the foundation of the actual socket preservation procedure is shown. We show it sort of through pictures. I show it step by step on a model, and then we sort of take it to the next level and show it for the video. So the model part is really crucial for being able to really catch little nuances and gain a better understanding.
I think the model was really important when you showed the different suturing techniques. So I think that's a kind of an aha moment when you see that. So it was very good. So yeah, I liked it. I liked it a lot. Next module is socket grafting in the aesthetic zone.
Okay, so this is where our course now starts to take it to the next level. This is where we now sort of take socket grafting to a different approach and a different level. And this is something that you don't actually see in other courses. They focus on just the basic socket grafting procedure, which we talk about in module 3. But now in module 4, we all know that aesthetics is a big thing for our patients. And when you take out a tooth, we know with remodeling and things just don't look as natural and great. And patients sometimes are unhappy because they're like, well, it's got a little dent here, things don't look good. So in this section, we talk about how to do the socket preservation procedure for an anterior site. And this takes a little bit of a turn into adding soft tissue grafting, because one of the key things for making something look natural and aesthetic is to maintain those contours. And for anterior aesthetic here is maintaining that ridge contour involves both bone grafting and soft tissue grafting. So that's a cool thing about this course is we now talk about things in the aesthetic zone, and you'll see how different they are. So we talk about how to maintain the ideal ridge dimensions. We talk about both bone and soft tissue in the anterior site. We talk about different types of soft tissue grafting, whether it could be something simple as a socket plug, a pedicle connected tissue graft, or a stuffed buccal connective tissue graft to get buccal contour. We also talk about uh, in the aesthetic zone how to use minimally invasive techniques to not damage the papilla and the shape and the architecture of the tissues. You know, for example, how to treat something that's missing a buccal plate, how to use a tunneled approach to restore and put a membrane and tuck in the bone and protect it despite having no buccal plate and other sort of approaches like that. So this is actually a really really good module. I think it shows a lot of content that usually is not discussed in most extraction and socket grafting cases. This alone, you'll find a lot of value and pearls in it. Just this will sell the course itself, and as we know, sometimes you can't always place an immediate implant in an anterior case. And so
Mhm.
that's what this module is about. It's for those cases where you either are restoring with a Maryland bridge, a regular bridge, or when you cannot do an implant immediately and you need something there to support the tissue contours. Another cool thing we talk about here is also the prosthetics. So the interim prosthetics. So we talk about provisionalization when you do a socket grafting procedure in an anterior case. How do you maintain and support the papillas, which is important because if you don't, things will collapse and it won't look as nice, and you'll have to kind of work on that and rebuild it later on. So this shows you how to maintain and keep those architecture of the papilla in, like the tooth was always there. So we sort of maintain what's there and preserve what is there originally. And I think these are little key pearls that you guys will all find really, really valuable for your practice.
It's an excellent module. I think this could have been the course in itself or a separate course, but it's part of the ESG program. And then to take it to another level, Nahid has added an entire module on GBR approach to socket grafting. So when you actually have to flap it and rebuild the ridge on an even more extensive, defect. So tell us about this one, Nahid. This was a really cool module too.
So yeah, this is another one of those key module that's going to sell this course. So this talks about GBR approaches, like Stephen mentioned. What this is cases where you have a ridge where you're going to be removing teeth, but there's just so much destruction damage, either from infection or advanced periodontal disease, that a simple socket graft will not rebuild the dimensions. These are cases where you're missing like buccal plate, lingual plate, you've got vertical loss of bone. So these are cases where you definitely have to use a membrane, and usually cases where you have to elevate a flap in order to access the alveolus so that you can rebuild the ridge to have implants placed. So we talk about how to create flaps in cases like this. We evaluate the site maybe using CT scan. We show you how to decide on how to approach your case. We talk about your flap design, how to open the flap and where to make it. We talk about types of bone grafts and membranes to use, how to use membranes properly in these socket grafting approaches. We talk about how to secure the membranes. As you can see in the image here, we show a membrane that is secured by sutures. So we talk about how to hold and keep everything stable, and how to treat cases like, well, like I mentioned, where you're having vertical bone loss, you have buccal and lingual or palatal plates missing, and sort of how to treat these. So these are cases where you can do a ridge augmentation procedure at the same time of extracting the teeth. So this is sort of like a bonus. It's almost like a GBR course in its own, but it focuses on cases where I'm going to do the GBR uh, right at the time of extraction. So we we call this our GBR approach to socket grafting module. And this alone also is another big course, and another valuable course that will add to what's already part of just the basic socket grafting procedure.
This is like a mini GBR course in the socket grafting course, masterclass, I guess. So,
Yeah.
mhm.
One of the things also we discuss, I didn't mention, but it's quite important, is we also talk about flap release. So in some of these
Mm,
cases, when we do
Yes.
GBR approaches, we show you how, even though it's a socket, we show you how to elevate and release the flaps to get primary closure to close up the opening of the socket so you can maximize your potential for bone regeneration. So, releasing the flaps, scoring periosteum, releasing lingual flaps, things like that are all discussed. So, like I said, it is a mini GBR course, and this will also help you with just your regular GBR procedures, despite
Mhm.
having sockets to graft.
This module, yes. All right. So again, there's been a link added to the side of the page. It's phelandentalseminars.com/ESG online WJ. And you might be asking, what is a masterclass? This has been a new concept the past year for us at Phelan Dental Seminars. And it's basically an online course with lifetime access. By lifetime access, we're saying 4 to 5 years, the life of the course, which is plenty of time to learn all of the content in this platform. There are no monthly webinars, so the master classes don't have monthly coaching webinars, but there's no renewal fee, so you get access indefinitely until we close the course, which we're telling people 4 years at this point. Last year we said 5 years, now we're saying about 4 years, so there's plenty of time for you to learn the material. You don't have to have a renewal fee. We do have a renewal fee and 12-month access to our monthly coaching webinar courses. And that's just because we're creating new content every month for those courses. So you get a year's access, and then if you want to continue, you can renew your course. This is not like that. It's basically lifetime of the course access. And what is the investment? Well, a couple of socket grafts in your practice would be roughly $19.95, 2 or 3 of them at the most, depending on your fees. And that's our target tuition fee for this course. But we're going to have a webinar membership offer while we relaunch ESG right today. And, you're going to save $700 during the next 2 hours. So if you join this course in the next 2 hours, you'll save $700. You'll be able to make one payment of $12.95, or you could make 4 consecutive monthly payments of $350. So one or the other, these are the two options. If you want to spread it out, you'll pay a little bit more, but you'll be able to get instant access to the program and basically pay for your payments as you do a case every month. Shouldn't be hard to do a case a month after watching even the first few modules. And we've also added, to make this even better, some bonuses to the extraction socket grafting masterclass. And the first bonus, you're going to get access to our suture clinic. So Nahid did an online suture clinic almost 2 years ago, and we had a replay video of it. It was about 3 hours roughly, and Nahid, on different plastic models, rubber models, went through and showed all the different suturing techniques that he uses in his practice. And the way we did it is he was showing members step by step how to do the sutures, then gave them a little time to do theirs. And so we'll let you know, you can buy these rubber models from Amazon, and you just type in dental suture model and this comes up. They're maybe $30. You could buy these on Amazon and then just get a good suturing kit with some sutures, and you could follow along and learn all of these suturing techniques. You showed a lot of different techniques in this one, huh, Nahid?
Yeah, we went over pretty much most of the suturing approaches that I use in my everyday practice. So it's good. You see suturing from tissue grafting techniques, suturing from GBR approaches, and then suturing from just a simple flap reflection. So
Mm-hmm.
it shows all you really need to know for doing any type of surgery in your office.
Yeah, and you showed continuous locking, all kinds of different techniques. I think it's like a little master class on suturing. We actually thought we'd make this into its own course. We just haven't had the opportunity to do that. It's a very valuable little replay video. And then bonus number 2 is actually a webinar replay from me where I used the Benex extraction system and I socket grafted this central incisor, and it had a buccal plate defect. I used the ice cream cone technique. We filmed this in my microscope, so it's It's in a lot of step-by-step detail. I'll tell you the socket grafting worked really well because 4 months later, I placed the implant through a tissue punch, just a small tissue punch, did not have to flap and gain more bone or even soft tissue. So it was a very nice technique. So this video with the replay of the clinical video of taking out the tooth with the Benex extractor, which is something if you haven't seen, I think you'll find pretty cool, as well as the grafting with the ice cream cone technique. You'll see how I did this, and it worked because we placed an implant a few months later. And then the last two bonuses are special webinars Nahid did for the members of my occlusion design course, and they were like multi-hour webinars. The first was simplifying bone augmentation, and this was a multi-hour webinar, probably 3 hours on bone augmentation. And this was the first training Nahid and I did together, and it was kind of this genesis of us doing the GBR course. So this was, I think, an excellent webinar. It was the first time I had ever seen a webinar where the instructor showed video in detail exactly how to release a flap. I'd always heard they say, and then you release the flap, but they don't show you in video how they actually do it step by step. Whereas Nahid showed you that in this, and it's something that can change your life if you do a lot of these cases. So that was excellent. And then he had another one for our members during COVID, minimally invasive soft tissue grafting techniques for teeth and implants. This was actually the genesis of us doing the STG grafting course, so the STG online course. So both of these you're getting free as bonuses. They're like 3 hour courses, little mini master classes on soft tissue grafting and guided bone regeneration. So, having just this bonus package alone is potentially worth the cost of the tuition of the course. But, the module 4 and 5 are very advanced. So we could have done the course module 1, 2, and 3 and these bonuses, and it would have been great value. But then having module 4 and 5, which are super advanced modules, plus everything else, it's a deal, really. I think it's a deal. The impact this can have on your surgical practice is huge for this small investment. All these procedures are pretty high value procedures from a billing perspective. So the ROI should be huge on this masterclass for you. And then just to point out the importance of this, I put in these slides from a patient. This is actually a dentist who has a failing rehab that came to see me from out of town. And unfortunately, she had these teeth taken out on the bottom and they didn't socket graft them. And she has huge defects. And here's the pan from a couple of years before she came to see me. And, she had like bone loss around these roots, but there was still potential to have a normal ridge here if they took them out and socket grafted them. This was done a few years before. You can see the whole ridge was gone. And she has a high inferior alveolar nerve, high mental foramen. So this was impossible to graft this. And then this one could have been an easy implant case if they had grafted this ridge. Instead, they didn't, and look at it. It's so low, and then the nerve is so high. We did a CBCT, and we just didn't have enough height for decent implants above the nerve. So Nahid's going to have to do an entirely different bone grafting procedure to rebuild these ridges to have any hope to do implants in this patient. Probably here we'll never get enough, but over here we're hoping we'll get enough to place 2 implants. On this side, I think we're going to have to do a bridge, a 3-unit bridge. But the other side, it's such a big space, we certainly don't want to do a bridge here. I can do a bridge here even though this is angled, but this side's, I really need some implants in here. So, if they had taken these out 2 years before I saw this patient with socket grafting, it could have made a huge difference for her. Unfortunately, she didn't know about us, that we would have wanted to do this. I saw her after the fact, didn't have any contact with her until she came in, like she was in the pictures I showed you. But they sent us this pan, and I'm like, oh my God, they just took these out. sometime in 2020, and I saw her in 2022. It was pretty sad because the bone had just all collapsed where the infection was, and it could have been rebuilt or maintained the height, and we couldn't. So we ended up, we're going to have to do like a more advanced bone graft for this lady to rebuild the ridge, and probably more bone grafting when we place the implants. So difficult case, which from what could have been an easy case had the patient had socket grafting at the extraction time. And this is what I'm trying to drive home is, even if you're not sure you're going to do the implants, you still should do the socket grafting because you're keeping your options open. It's better for prosthetics, and it's just a better option for your patients. What do you think, Nahid?
Yeah, definitely. I mean, it just makes things more simple just from, a morbidity standpoint for the patient. It's so much more easier to just remove the teeth and socket graft it. You maintain the volume. In this case, we would have maintained the vertical height. Now you can see we're doing some extensive vertical augmentation that's, more unpredictable and more invasive in order to try to rebuild all this bone back so that she can have implants.
Mm-hmm. Yeah, it's unfortunate. But that's kind of one of the messages we wanted to give all of you, is to make sure you don't do this. You do the option of the socket grafting. I think almost any tooth that comes out in our practices these days, the patient should be, I can't say forced, but should be persuaded into having extraction plus socket grafting. Don't you think, Nahid?
Yeah, because it's what it does is, they call it socket preservation as a different name for a reason, because you're preserving the natural biological ridge contours. Whether it's
Mm-hmm.
for an implant or a bridge or just for support of a denture, maintaining that bone and those ridge dimensions is important. And so there's multiple factors, not just implant related. A lot of people just say, "Oh, I'm going to put an implant, do a bone graft," and "Oh, you don't want an implant, you don't need to." But
Mm-hmm.
in my practice, any tooth that comes out, I always push for a socket preservation. I'm like, you know what? You need this contour. Whether you decide to have a denture, you'll need it for support. Whether you do a bridge, you'll need it for just aesthetics to make it look more natural. Or if you decide that you want to have an implant, hey, you've got the bone there. So it just makes it a lot easier. It's easier to preserve something and get a good result than to have to reconstruct.
Yeah, I agree. And
And
that
it's
leads
cheaper too.
us, sorry,
It's
Nahid.
cheaper too.
Cheaper. Yeah,
Go
yeah,
ahead.
for sure. That's true, actually. So that leads us to questions. Let me look at the questions. We have a few different questions. If I joined ESG, where do I need to go to watch the suturing live stream? Okay. So it's actually in the portal. Let me show you all the portal, and I can show you really quickly. So if you go in the portal, the suturing is right here on the front page. So you've got the modules. We had a bonus for charter members, which is recorded in here. And then the suturing clinic is right here. And then when you click on these in the portal, it was 3 hours and 30 minutes actually. So here's the video. You could make it full screen, and you could
Okay,
totally
everybody,
control,
attention. You
you
can
can
grab.
control the video, control the speed. You can see how detailed Nahid got right close up to show everybody exactly what he's doing. So close up, so you could see exactly what he's doing,
Running across,
loop by
seeing where
loop.
it falls over, so I know.
And we actually had two views because we have this view here from his laptop, but you can see the really close up view here. So I thought that was pretty cool the way that we did that. And again, he showed all kinds of different sutures. You look how close up this is. Really,
And
really
we'll come
good.
back around to where we started.
So yeah, this is, in my opinion, a really good bonus for all of you. And then the whole portal is just here. Let's see. What do you think of Max Zeus allograft bone? It's Max Zeus. Any thoughts on that?
So it's Maxius, I guess. Yeah, it's just a
Maxius.
different
Okay.
brand. Uh, to be honest, most allograft bones are pretty similar. You just want to look at the type of allograft, whether it's demineralized or mineralized, freeze dried, and then it's cortical or cantillus or cortical cantillus. That's what's important. But on average, most allografts usually are the same. If you want to know, usually what you'd want to check is the brands, where they get the actual bone graft. That's important. So you want to see where the tissue bank comes from, and
Oh,
see,
okay.
that if you're interested in doing the research, you can kind of research where the tissue bank is and then go look up their name and see if they're reputable. But all in all, usually most, like I find most allograft bones are usually the same. So
Mm,
some people will say theirs is better and theirs is not. I've used a few uh different ones, and to be honest, I don't find a huge difference.
mm.
So as
I'd
long
have
as
to
it's a
say the
reputable,
same. I've been doing this for about a dozen years. I don't know that there's much difference between one or the other, as long as they're all allographed from a reputable company, don't you think?
yeah, I would just make sure at least the company itself is reputable or is known.
Hmm.
It's not just a unknown company. But
Hmm.
do that, you should be okay. And then, like I said, if you want to do further research, you look at the bone graft, see which tissue bank it comes from, and then you can do some research on the actual tissue bank itself. There's not
Okay.
many in the US. There's, I think, four probably main big ones which
Mm.
provide a lot of the bone tissue.
Do you know where Strawman comes from?
Straumann is LifeNet, so it
Okay.
comes from the LifeNet tissue bank, and they're a pretty good brand. So LifeNet sells their their bone or their allograft under multiple names, but like Straumann has it. I think they also provide for some other implant providers, but it's still LifeNet bone. The Orograft itself, the Orograft brand name is also LifeNet bone.
Mm. What
So
about Puros?
so Puros, so Puros is different. Puros is usually it's twice the price
Yeah.
almost of your regular allograft bone. Puros has they claim they have their own sort of proprietary method to clean and cleanse the bone and sort of have the bone go through its processing, which
Hmm.
they claim gives you a better, cleaner bone that remodels faster and better
Mm.
than other brands out there. I haven't used enough of it to really give you a real answer whether it's better or not. All
Okay.
I know is it's double the price almost. Like for
Yeah.
example, a zero point 0.5 cc of any regular, allograft is usually around $50. A
Hmm.
Puros one is about 105 or 120 for the
Mm.
same amount. It's a lot more expensive. And
Hmm.
to be honest, personally, I haven't found any issues with the existing allograft bone that I use.
Hmm.
So it's really difficult to justify the doubling of the material cost without a
Yeah.
need. But that being said, uh, I don't know enough. I mean, I haven't used it enough to actually see
Mm.
a lot of responses. I know recently we've had a meeting with the guys from Zimvi, which is Zimmer Dental, and they've
Hmm.
given some samples, and we'll try it out and see. But again, like I said, a lot of times if it works and it's cost effective, it's kind of a balance of both.
Hmm.
But they claim that theirs is better, and it may
Yeah.
be, but
I did use Puros quite a bit about 8 or 9 years ago, and then suddenly, I don't even know why, but we switched to the Strawman just to kind of streamline ordering because Strawman we order
yeah,
all the implant stuff. So I started using Strawman. I can't tell you if I can tell that there was much difference, to be honest. I haven't, like, it didn't strike me as, oh, these ones aren't working as well or anything like that. So I'm not sure.
yeah. So like I said, maybe histologically, if you take a bone core sample, you can see more vital bone faster, but
Hmm.
clinically in practice and with regards to you using it for implants, if you don't really notice a difference and you're not having any difference in implant failures, then
Yeah, I'm
it's
not
hard to
sure I noticed much.
yeah, then you can't justify paying double.
Yeah. Um, how long does the bone graft stay there if no implant is placed? Does it shrink quite a bit? Like, how long does it take to shrink? That's one of the
So
questions.
So there's different variations. So first of all, uh, it stays somewhat present for about a year. Okay.
Hmm.
But as it goes through its phases of remodeling, you kind of get some initial remodeling in the first 3 months. And then you kind of get to a point where it kind of stays stable for the next up to the 12 months. Usually after a year, when there's nothing stimulating the bone, then you start to see resorption. And it also depends on what material you use. If you're using allograft, then after a year. If you're using xenograft, you might have a little bit more. If you're using something synthetic, then you might be able to maintain the volume a lot
Hmm.
longer. But the quality of bone may be not as good as using an allograft.
Yeah. Like they basically say the xenograft is better if you're better making
If
it
you
as a pontic, right?
Yeah. So we talk about this specific point in the actual course. We talk about when to use synthetic, when to use xenograft, when to use allograft, and
Uh-huh.
why. So we go over, and it has to do with turnover time and remodeling and what the approach is for. Like, for example, if I'm taking out a tooth and I know it's going to be a bridge and I know the patient's never going to have an implant, then I'm going to put a synthetic material in there that has a very, very slow turnover rate because
Hmm.
I want to maintain those ridge volumes for as long as possible. So that's
Hmm.
where synthetic is the way to go. But if
Yeah.
I have another patient who is like, I need this done ASAP. Let's take out the tooth. Let's get the implant in 3 months. Let's get the tooth. If someone is ready to go and they want everything done really fast, then I'm gonna go towards something like a corticocancellous allograft bone.
Okay. That'll be quicker. Uh, are you using socket preservation? Are you using ground dentin from extracted teeth?
Uh, no, and I'll explain my reasoning for this. Okay, and so ground dentin. I've seen a few cases. I haven't done any, so I can only see from my observations. I personally don't like the quality of the bone, the way it looks. It still looks very granular. It doesn't look like it's fully remodeled. So from that point, I'm not a big fan of the quality of bone that you get. That's one. My second, I guess, reason for not using it is allograft is so cheap. It works well. It can be done and placed very easily and very fast.
Hmm.
So why would I take a tooth, have to clean it through a cleanser and some sort of liquid to clean it up, then crush it and grind it. Then you have to like dissolve or wash it, and then it's ready for implantation back in the socket. By the time my dentin bone graft is ready, I would have been done my procedure and the patient is already driving home. So from
Yeah.
a production standpoint, from saving the patient money, and from me being effective with my time and my production hours, it just makes no sense. The only benefit I can see for this, and this is just my opinion, is just for scientific purpose and scientific investigation to know that it's there and it can be done. But really,
Mm.
allograft just works better. Why would I change it? And it's cheaper.
Yeah, that makes sense. If you have a sinus perforation, would you still do your socket grafting?
Yes, it depends. Now, if you have a small little sinus perf, then yes, we would still do it. In the course, we actually show how to plug and seal it and continue with your grafting like nothing happened.
Hmm.
If you have basically a massive hole, like you take out the tooth and you basically remove the entire floor of the socket, and the sinus membrane has been perforated and torn, and you just have this big gaping hole where you can stick your thumb in, then
Hmm.
that's different. Then we don't. That's called an orangeal fistula or a communication. That is
Hmm.
then covered and sealed and through a different approach using an extended flap or some buccal fat pad. So that is a whole different thing. That's sort of what we'd call an extraction complication. But a simple little perf, let's say in one root, you got a little perf from infection or those are not big issues. They're easily treated with ways to seal and plug it, which we show in the course.
Okay, perfect. Uh, is it better to cantilever mesial or distal for upper premolar implant? I can't imagine doing either, right?
No, I mean,
I don't get it.
as a
Like I would
general
only
rule,
cantilever a
I mean,
lateral.
mesial cantilevers are preferred as to distal, but that's only
Yeah.
because of the way the force is, and we would do this more for anterior teeth, like a canine
A
cantilever
lateral.
lateral. Yeah.
Yeah, that would be
With
what I would do,
on a
not
functioning posterior tooth, I would not cantilever.
no.
The only time we do a cantilever is if it's basically a complete arch restoration,
Yeah. Yeah.
and it's basically one piece, and then we can do a distal cantilever, and that's just because the way the structure of the prosthesis and the way forces are spread, and
Mhm.
these are just full arch cases, so it's a whole
Mhm.
different ballgame. But for single
Yeah.
unit teeth, I personally would not recommend
Yeah,
it.
I would say never.
Yeah,
Uh,
put two implants.
yeah. Yeah, exactly. Do you use PRP, PRF in your socket grafting?
I don't anymore. You can use it. You can use PRP to soak the bone in there,
Mhm.
and you can use a PRF plug to seal the socket. But to be honest, a socket, if it's intact, is basically a five-walled defect. So it's the most regenerable defect. That means
Mhm.
that you can put anything in there, it will regenerate bone. So there's actually not a real need for PRP
Okay.
to do it. And then same thing with PRF. You can use a PRF plug to help seal the top of it. Again, it's not necessary. I've done it. I don't see a huge difference between that and like some of the other collagen plugs and things. But
Mhm.
you can, and it works. Uh, but the only time I would ever use some sort of modifier like PRP or PRF in the socket with the bone is usually in cases where patients are on sort of bone metabolism medication like Prolia or oral bisphosphonates or things like that.
Mm.
Or let's say I don't see a lot of bleeding and we want to enhance the growth factor chemotaxis to the area to help with the healing and help with the remodeling and revascularization of the site. So those are the only times I would, but they're done not for the socket grafting procedure itself, but more because of their patient's medical history.
Mm. Makes sense. What makes you choose between mineralized cortical allograft and mineralized cortical cancellous allograft for socket preservation? And if all work equally, straight mineralized cortical is less expensive.
Yeah, good question. Technically, mineralized cortical cancellous will actually turn over faster because of the cancellous portion
Okay.
than the cortical. But that being said, if you're waiting normally 3 months, 4 months, you can use either or. You can use cortical allograft, and you'll
Mhm.
still get good solid bone, and it's cheaper. You're right.
Mhm.
So technically, both
Aside
work.
from
It's a matter of time.
price, what would be your preference?
For sockets, I do cortical cancellous. Sometimes I do
Mhm.
cortical. It depends on what I have. I don't have a choice, but I would go if I were to pick. I'd pick cortical cancellous for a socket.
And would you go 70-30 or 50-50?
You know what? I don't think it matters. I've done both.
No. Okay.
I would probably go. I think it's 50-50 or so. To
Mhm.
be honest, I don't even know. I have to look at the
Okay.
chart.
Doesn't really matter.
But I honestly, I don't think it matters.
Okay. Perfect. How do you determine the extent of dehiscence if you've taken a tooth out and there's a missing buccal plate? You just probe it or?
Yeah, the easiest way is to just use a probe, feel
Mhm.
down the socket, and you can feel where the dehiscence is and
Mhm.
where it starts, and then see how deep it goes, and you can kind of measure with the probe. So a probe is usually what I tend to use to see the dehiscence and see how deep it goes, and then make the decision on how to treat it.
Okay. Does Dr. Muhammad have any tips for extracting teeth with failed endo, especially when the root is highly fragile and brittle?
Yes. If you're worried about
Module
root,
two.
yeah, the module two. Okay, but basically to make it simple, if you're worried about a tooth that's brittle and it's gonna fracture, then pull out your drill and section it and create space.
Yep.
I will
Yep.
talk about how to do this in module two.
Perfect. How do you luxate a premolar or canine that is fractured horizontally below the bone level?
With the special instrumentation that I show you in module two.
Yeah.
So
The
again,
different.
these are things like some cases you do have to pull out the drill and you do have to remove a little bit of bone to get access for your
Mhm.
luxator, but there's specific luxators that we use and ways to section and drill around the teeth with special burrs that we go over to take out things like broken roots that are sort of below the bone,
Okay.
below the gum line.
Hi, Dr. Nahid. Would you still use a flipper or an Essex to maintain the Pontic shape if you were only missing one tooth?
Yes, because each tooth has a papilla. So if it's
Yeah.
especially for it's a posterior tooth, it's I usually don't unless the patient requests one. But for anterior teeth, definitely, we want to have something fit in almost like an ovate pontic into the opening of the socket and to
Mhm.
fit tight and snugly around the soft tissue to support the papillas. So
Okay.
yes, even if it's one tooth, we still do it.
Okay, and follow up, when you're placing the Pontic, how much pressure do you have on the grafting site? I thought we wanted to avoid any pressure on these.
No, so the pressure we want it to fit snugly. There's not too much pressure. Like you don't want to see blanching, but you
Mhm.
want it to have contact. And the contact is more for the arches of the papillas. Right
Mhm.
on the actual bone graft itself, you don't need to have too much pressure, but even if you have a little bit, it's okay. There's usually some sort of a collagen plug or membrane there as a barrier. And if you have a light bit of pressure, it's okay because uh, I usually overpack my sockets anyways, so you have a little bit of buffer zone. And remember, if you're aware of implants in the anterior ear aesthetic zone, we
Mhm.
always, in order to build emergence profile, we have to have our implants deep, at least 4 millimeters, below the intended gingival margin, so that you have space to kind of develop an emergence. And
Okay.
so with that, you have a lot of space to work with. But I've never found that you have much resorption because the resorption, if it does happen, will be just where the pressure is. And it's literally like once you resorb a millimeter or half a millimeter, there's no pressure anymore. So
Yeah,
it's not really consequential. It doesn't really matter.
makes sense. Um, what are the mini criers called?
Uh, they're called mini criers actually. There's
Okay.
there's an actual code for them. It's like it
You
depends on the
show it.
company.
You show it in
Yeah.
module two. So in
We show
module
it in
two, Nahid gives a printout of all the instruments he uses. He shows them like slide by slide with names and numbers and everything else. So he goes through it in great detail. It's module two, right, Nahid?
Yeah, module two with the instrumentation.
Yeah. And you show all the different special ones you use. I think you said there's only 8 instruments you really use.
Yeah, like I said, we streamline it to make it easy for you, so you don't even have to
Uh,
buy a lot of instruments. And I
yeah.
show you the few instruments that I use, which you can pretty much take out any tooth.
Yeah. Yeah. So if they had those 8, they could probably do almost anything except for wisdom teeth.
Yeah.
Which for wisdom teeth, your cousin will help them with that. Well, he just did the wisdom tooth extraction course, so or we're building it right now. Um, what can you repeat again the antibiotic you use to irrigate the socket?
So there's a few things you can use to irrigate the socket. Sometimes it's just simple thorough debridement irrigation with saline, which is I do
Mhm.
most of the time.
Yeah.
Uh, Then you can use an Ansef solution, which you can just make yourself with a tablet and a saline uh,
Okay.
solution. You can even use chlorhexidine sometimes. I don't use chlorhexidine. To be honest, most of the times I basically just use just sterile saline and a good curettage and debridement.
Yeah, that's what I've been doing. I think
Yeah.
it's the way to go, really. Um, For the ice cream cone technique, can the membrane be placed between the bone and periosteum?
Yeah, so usually I don't. I know sometimes diagrams show it where it's put in the socket. I actually want all that volume in the socket. So I actually tunnel a space between the sort of flap and the buccal plate. So where the periosteum is, we kind of stuff it in there.
Yeah, that makes sense. With your basically your tunneling instruments, huh?
Yeah, you can use an actual socket curette if it's small enough as a tunneling
Yeah,
instrument, or just use a tunneling instrument, which is a little bit easier and safer.
yeah, yeah. Less perforations. Let's see. I'm just looking through the different comments. What suture and needle are you typically using? kind of as your go-to?
For sockets, I tend to just bleed most of the time with a P3 needle. And then the sutures, it depends on what I'm doing, but usually I'm using a 5-0 monocryl or a 6-0 proline.
Okay. And do you think the O6 plus membrane gives better results with larger grafts or larger socket grafts?
So Ostix Plus, I would not use it in a socket preservation.
Hmm.
It's more for GBR approaches because Ostix Plus, it's a cross-linked membrane. They tend to not do too well when they're exposed. And so I wouldn't use it in a socket itself.
Hmm.
Uh,
Yeah, you're basically showing the PTFEs, right?
yeah, yeah.
Yeah.
So we basically use Ostix in GBR approach where you can fully cover the
Mhm.
site. They work well for growing bone. Just it is a good membrane. It has a little bit more of a tough handling because once you lay it down, it can't be stretched and repositioned like BioGuide. It
Mhm.
breaks and tears, and you can't tack it either. You can only suture it to secure it. So
Yeah,
it is a little bit of a different membrane, but they do work well, provided everything gets closed up nicely and you
and
have a good
covered.
response. Yeah.
Okay. Um, let's see. Have you used the bio-exclude membrane? Can you use that for socket grafts?
Yes, I have used the BioExclude membrane. It can be used as a membrane over the top of the socket. It has growth factors impregnated in it, which is supposed to help epithelialization, help close the socket. And yeah, you can use it to seal the top of the socket. I usually, if I use it, I'd still kind of use a collagen plug on top of it because remember, anything that's exposed into the mouth will start to naturally break down.
Yeah.
So I try to protect it with a little collagen plug over it. I sort of put the bone, then I'll use
Don't you
the.
find those break down pretty quick too?
They do the collagen plug or the
Yeah, the
BioExclude.
collagen plug.
Yeah, they do. That's why sometimes it's just there to kind of create a clot. That's all it does.
Yeah.
After like a week, 10 days, it's pretty much started to break down, and you just see like a fibrin clot there,
Yeah.
really.
It's
So
probably not even
I
there in a
I
week.
only use collagen plugs when the socket is completely intact and
Yeah.
unmaintained.
Okay, makes sense. And as a follow-up for that, somebody's asking, do you take a bite out of the collagen plug when you're suturing it
No, I compress the plug down and then I suture over, so we sort of make a
over
little
top
net
of it?
on top of it to hold it. Yeah, we don't
Okay.
actually do it because when it gets soaked with blood, it tears and breaks. So taking a bite out of it doesn't really do anything. It'll
Mhm.
just break.
Okay, so somebody wanted to see the page where you would join. So here it is, ESG Online WJ. You can save $700 today. As we said, it's a 2-hour offer. If you look here, I clicked on it a little before you guys would have. So we are offering you a $700 discount, and we're offering it for people who can make a decision and go ahead and decide to join right away. If you don't join, you won't be offered this again for, I think, 3 months. The way we do this is it's locked down for 3 months after you decide not to join. If you want to join, you click here and you come up with the page where you can join, which gives you the options, 4 payments or one single payment, and then you just fill in your info, click on it, and you can join the Extraction Socket Grafting Masterclass. All the information on the masterclass is here. You can see the modules, you can see all the information, each module's information. Everything's already in the portal ready for you. Each module again in detail so you know what you're getting. We've gone through that, but this way you know what you're getting. Each bonus, you'll know what you're getting with the bonuses. And there's also CE points available for each of the modules. So we've got a whole package here for you. CE points, we're an AGD PACE program provider. So we've got CE points as well as, beyond the CE points, just the ability to have all of this information. In the portal, the portal, when you click on it, you've got each portal's module videos, all the detailed module videos. Below the videos, you can ask questions. Each module has its own set of videos. And so this module has even more videos. He added additional bonus videos because people had some different questions. So he added additional bonus videos. Actually, has surgical removal of an impacted canine. This is a cool little video he just added. And then this one, this was, what I found very valuable here was actually the step-by-step on the model. I thought that was really cool. And just the way he went through everything.
At this point, we will.
I thought it was very detailed. And I liked just seeing, how he's placing the membrane and then the exact suturing of these. I thought this was, as I said, just really valuable. Step by step, how to get these sutures. This suture here, very simple suture, but the way he explained this, it's actually way easier than the way I used to do it. So more effective too. I did one, stayed in place for 5 weeks of a big defect. So that is really good there. And then you get into the modules with the bigger cases, anterior cases, or GBR cases. So there's a lot of content here. The GBR actually has extra videos even as well, bonus videos, case studies. Again, big course really for what you're getting as a masterclass and this tuition. I think the ROI should be very significant with this. And I think, if you're interested at all, you should take the opportunity to join while it's still available before the countdown gets to 0, because once it gets to 0, you're going to not have this offer again for, I think it's 3, maybe 4 months. So I think we've answered pretty much all the questions. If we've missed your questions, sorry. We're going to, periodically get a summary of the questions and take a look at the ones that we've missed and maybe create some little content videos for them. At one point, I used to do some videos of webinar questions. Once Nahid has a little more time, we'll probably get him to do some of those too, because it gets people really interested in the different webinars and the programs, and it gives some valuable content information to potential members. So once again, we have a webinar membership offer. Once you click on the page, you have 2 hours to join, saving $700 over the next 2 hours after you click. Once it counts down to 0, it's over. And this is just, again, our incentive for people that make a decision, decide to join. Without us, incentivizing you to join, you'll think, okay, I'll join tomorrow, but then tomorrow's busy and you totally forget about it, and you have an extraction case that you want a socket graft that's in the chair, and you're like, damn, I didn't buy the course. I should have bought it, because if I bought it, I'd be ready to do this case today. And you have regret because we didn't incentivize you to join. So without incentive, people generally don't jump on things. So your incentive is, you've got this offer, great offer to buy this course at a really good tuition fee, great ROI, and basically over the next 2 hours. So hopefully you can make the decision to join and to be a member of the Extraction Socket Grafting Masterclass. If you have any questions after this and you're a member, you can ask questions under the videos on the membership site. Nahid will answer your questions under the videos. We won't have monthly coaching webinars, but you can get answers to your questions by just asking them on the membership site. So anything you'd like to add about the course, Nahid, before we sign off?
Not much, but like I said, there's not any courses that cover this sort of entire scope of socket grafting, such as this one that I know of, that especially focuses on like anterior aesthetic zone as well as GBR approaches. I think Stephen mentioned the ROI. This is something that you as a general dentist will do almost every day in your clinic, whether it's just simply buying the course for learning how to do the extractions much more efficiently and faster, to learning a very simple productive procedure that will help you and your patient. You'll get a lot of satisfaction from providing additional service, as well as producing a lot more financially. So it's a sort of a win-win, and at this price, it's a no-brainer. Even if you do like 1 or 2 of these a month, you've paid for the course. So I think it's definitely something that you should seriously consider because it not only will give you more skills, it will enhance the services you provide for your patients and improve the well-being of your practice.
Amazing. I agree. Great ROI, better service for your patients. You won't have your patients like that poor dentist who had 2 teeth extracted and now has to be rebuilt as opposed to preserved. I just think it's a great opportunity. I don't personally believe, I've told my associates this, no teeth should be extracted in our practice without a socket grafting. I just don't think it should be done. I don't believe it makes any sense at all. So thank you again for joining us. I hope you have got lots of value out of our time together today, and I hope you become a member of the Extraction Socket Grafting course. Thanks again, Naheed, for all the great teaching and the Q&A. I appreciate your time, and we'll talk to everybody soon.
All right. Thank you, guys. Take care.
All right. Take care.